Welcome to today's online presentation In the Know with RNAO National Webinar Series on Multiple IV Infusion Safety and Nursing Education Implications. So again, just wanted to let you know that this webinar will be recorded and archived. And make sure that your volume is on and that it is up. You will only be listening to the webinar. You'll be in listening mode for the presentation, but there will be opportunities to ask questions during the presentation by typing your question to the chat box and located on the right side of your screen. You wish to be interactive and engaging, so we do encourage you to type in the questions and comments in a chat during the presentation, and we will address them at some point in the presentation. If you are unable to answer all questions in our allotted time, we will respond to them in writing and post it on the RNAO website event page. For the call today, we have myself, Grace Uva. I'm a program manager at the Registered Nurses Association of Ontario. I'm one of the managers who is responsible for guidelines development and also the implementation of the BPG. We also have in the room Grace Wong, and she's a project coordinator who works with myself in terms of guideline development and implementation. One of our speakers today is Sonia Pinkney, and she is a human factors engineer with Humanera, University and Health Network, Toronto, Canada. She has over 10 years experience working on healthcare and technology-related projects in both the operational and research roles. Her spans the life cycle of technology, including designing award-winning technology, procuring and implementing diverse medical technology, and managing critical patient safety incidents. Her passion for healthcare safety led her to join Humanera in 2007, where her area of focus is on using human factors methods to improve the safety of intravenous infusions. Welcome, Sonia. First speaker, Christine Koshmera, and she's a registered nurse with over 25 years of nursing experience. Christine has worked in areas and roles, including as a clinical care leader in an intensive care unit. She has been with ISMP Canada for over 12 years as a senior analyst with responsibilities that included error report analysis, research, packaging best practices, and co-leading the ISMP Canada Safety Bulletin. I'll be presenting today on behalf of ISMP Canada. On today's agenda, it will be an hour-long webinar that is intended for nurses, nursing students, and educators who manage multiple IV infusions administered in clinical settings such as critical care, medical, and pediatric units. So what we will cover today will be RNAO, a brief overview of RNAO with regard to the evidence-based practice, regarding specifically vascular access and patient safety, and into the multiple IV infusion safety, so an overview of the risks and the evidence and best practices. Then we'll end off with a demonstration and overview of e-learning modules, which have been developed by Humanera, and which are through the RNAO website, support nurse training on multiple IV infusion safety. First off, about Registered Nurses of Ontario, or RNAO. It is the professional association for nurses in Ontario and excellence in nursing practice and advancing nurses' contribution to the healthcare system. And our slide is our signature program called the International Affairs and Best Practice Guidelines Center. And in the three concentric circles, we're involved in guideline development as well as the dissemination, implementation, and sustainability of those best practice guidelines. So we have various projects relating to those. And then we have Enquire and other projects with regard to evaluating and monitoring the outcomes, both of patient, provider organization, and system outcomes with regard to the implementation of guidelines. And we both clinical and healthy workplace environment best practice guidelines in our program. Is based on evidence in terms of the signature program IABPG program, the best practice guidelines program. To complement the multiple IV infusion safety content that we're talking about today, we also have some established vascular access BPGs, assessment and the selection, and the other on care and maintenance. In best practices and evidence, we have to host and collaborate with Humanera with regard to their and the e-learning is based on research conducted by Humanera. They've in fact developed the best practice guideline on multiple IV infusion infusion safety. And one of their recommendations is to educate all nurses and nurse trainees on the physical principles and best practices related to administering IV infusions to minimize setup errors. And more about this in terms of the e-learn presentation today. In line with RNAO and multiple infusion safety is our belief that patient safety is a priority. So exist in our program having to do with clinical guidelines that focus on patient safety, for example, falls guidelines, restraint, client-centered care, or transition care. We also speak about healthy workplace environment guidelines in terms of their impact on patient safety. So, for example, nurse fatigue. We're also in implementing as well as evaluating the implement best practices and its outcome on patient safety as well as other outcomes. So we have the best practice pilot organization, which is where organizations enter a 3-year contract with RNAO to formally implement RNAO BPGs into their programs. And then we also have an evaluation program called NFIRE, our Nursing Quality Indicators for Reporting and Evaluation, where we go to evaluate the outcomes, including patient safety, with regard to implementation of these best practices. So national, that we partner with Humanera to be able to address multiple IV infusion safety as it's in line with our priority on speaking out on patient safety. Okay, for a brief introduction to RNAO, I'd now like to pass it on to Sonia and Steve to talk about an overview of their project.
Everyone, thank you, first of all, for this opportunity to really engage with you about multiple IV infusions, an issue that we've been passionately studying for the past 4 years, thanks to the support from Healthy Ontario. And the lucky ones to be presenting to you today, we really can't proceed or start without recognizing the huge effort of the entire team, not only from our respective organizations of Humanera and ISMP Canada, also from our various project expert committees, our expert reviewers, and of course, all our study participants and hospital sites who dedicated their time to support this work. So while I share with you all the findings and recommendations we have about administering multiple IV infusions, I'm really just going to focus on more of our education-based findings. So goals for today are really twofold. First, we'll provide a quick introduction to our study and summarize some of our findings related to the need for this education. And second, we'll provide you with a quick overview of the e-learning modules we've created to help fill these education gaps. Start by providing a very quick overview of this project. Started back from research we were doing focusing on the smart pump technology, really back in 2008, where that while these pumps can help catch some types of medication errors, they do address all medication errors, particularly when you start to look at some of these setup errors when administering secondary infusions, in which 2 infusions are administered by 1 pump. And realize that these gaps in technology really extend to the many, many challenges that arise when trying to manage the complexity of multiple concurrent infusions being administered to a single patient. In discussing this issue with nurses, we walked around with this photo shown here, and we found nurses taking this photo and starting to count the pumps and say, this is nothing. You know, the other day I had a patient on 16 infusions. And so really be this culture of pride in terms of how much complexity we could manage, or simply that this was just the way things were. But if you take a step back, the status quo can really seem bewildering. And perhaps one of the reasons this issue hasn't gotten much focus until now is that unlike falls or infections, it isn't possible to really accurately quantify the harm occurring to patients stemming from this practice, since most incident-based databases can't really explicitly capture this information, nor is it possible to kind of an observation study, because you simply can't observe all the errors associated with this issue, given the sheer visual complexity of it all. The study works simple. We didn't attempt to quantify the prevalence of errors, but based on reported incidents, we knew errors were occurring from administering multiple IV infusions. Therefore, focused on identifying the specific risks of this practice, evaluating and validating the effectiveness of different mitigations to province to help minimize the risk. Method approach to help answer these questions. I'll review all our methods in detail, except I will highlight that we did do a systematic literature review. We analyzed 2 national incident databases. We had vendors and analyzed all the different products licensed for sale here in Canada. We conducted field observations with 12 hospital units in Ontario to really observe and get an appreciation for all the complexities such as the workflow interruptions, how information is being communicated, the contextual information. We reviewed nursing instructors at our colleges and universities to understand how nurses are being trained about administering multiple infusions. We did a provincial survey, and finally, we conducted a simulation lab with 40 ICU nurses to perform tasks both with and without and then with interventions, so that we could really compare and quantify the effectiveness of different interventions to the identified risk. So from the work, we had various photos such as these of real clinical setups to simulate the environment in our usability lab. And so I'll show you now a clip of what it looks like when it all comes together in our simulation lab. And video, I'm in the center of the screen there, and I'm playing the role of what a nurse participant would be doing. And there's another nurse and actor played on either side of me who are actually members of the research team, and they're really there to guide the scenario or help set up distractions. In this video, you'll see that sometimes the camera will switch views, and you'll see behind a one-way mirror, and there you'll see 2 human factors specialists observing and recording the participants' actions, as well as kind of helping to direct the script. Now, because this is a webinar, this may come through across onto your computer a bit choppy. The main purpose of showing the video is just to get a feel of what the simulation study was, as opposed to get all the details of what's occurring in the scenario. Step in our study was really to review all these findings of our expert panel and OTAC. And OTAC is the Ontario Health Technology Advisory Committee. And we made evidence-based recommendations. And these recommendations are really grouped into 3 buckets. The first, practice-based recommendations, and these are really meant to provide clinicians with kind of standard rules to intentions. The second bucket is design-based recommendations, and these are intended to ensure clinicians have devices that can ensure their actions match their intentions, that they don't have devices which are introducing new errors simply by the way that they've been designed. We have our education-based recommendations, and these are intended to ensure clinicians really have the required knowledge to develop these correct intentions, particularly in novel or infrequent situations where rules or best practices may not exist or are unknown. Last bucket that we're going to focus our attention on today. So we focus on the risks in the following 5 themes. The first is setting up and programming multiple primary continuous infusions where there's risk, for example, of mix-ups. The next, identifying an infusion when you have a spaghetti-like mess at the bedside. Third is managing shared infusion volume, which is, we'll discuss a bit more later in this webinar, but it's also been referred to as dead volume. The theme is setting up a secondary intermittent IV infusions where there's a particular risk for many physical setup issues. Fifth and last theme is about administering an IV bolus dose using a pre-existing continuous infusion and using the pump to administer that dose. We don't have time to go through all these themes and our findings, but today we're going to take a closer look scenes 3 and 4. As these are scenes where we had our most education-related recommendations. So for scene 3, which is about shared infusion volume management, and I'll now refer to Christine.
And hello, everybody. Thank you for joining us on this webinar today. So what exactly is shared infusion volume? Infusion volume has been called many things, and Sonia just alluded to it being called dead volume. That's one of the names, and it's also been defined in many ways in literature. The definition we'll use today is the common volume shared by 2 or more infusates. So what we're focusing on is the 2 that's highlighted in red. Shared volume starts from the where 2 or more infusions are joined together and mixed together in the tubing and the access ports until they enter the patient's bloodstream. Running more IV together is just one example of shared infusion volume here, as listed under number 1. Sharing may also be an issue with other setups, but when medications and fluids are administered one after the other, such as administering an intermittent secondary IV infusion, when an IV push bolus, when changing concentration of an IV bag and perhaps using the same IV tube rather than initiating a new setup. The key issue with shared infusion volumes is it can result in unrecognized and potentially dangerous reservoirs of medications leading to various errors, such as an active bolus, or medication being administered. A therapy, if medication takes time to clear the shared infusion volume and reach the patient, or incompatibility. In our lab, we explored the issues with all these tasks, and here are some examples. When a minute push dose of furosemide 40 milligrams into the line that was KVO is shown here, 30% of the nurses did not flush the IV line after administering the IV push dose, leaving reservoir of furosemide in the IV tubing. Of those flushed, 9 flushed at the wrong rate, resulting in the residual medication in the tubing being administered too quickly to the patient. So furosemide in this instance results in auto or nephrotoxicity. When the error rate was so high, the volume of medication and the volume of flush were different. The IV dose of the furosemide had a volume of 4 mL, where the flush volume had 10 mL. Although most pushed in flush very quickly, those that did consider the flush rate for the medication flushed the entire 10 mL pre-filled syringe of the 0.9% chloride over 1 minute, just as they did for the syringe containing the furosemide 4 mL, not realizing that these are not equivalent per ml rate. In fact, the 2 syringes containing 2 different volumes were flushed over the same time frame. This is actually thought about the rate, measuring the furosemide at 2.5 times the maximum recommended rate. Canada Safety Bulletin, published in 2013, also noted that the rate of administration of the flush, whether to syringe or infusion pump, can also be critical, as the flush will affect the overall rate of the drug administration. The drug is in the tubing. If that's given too quickly, as we did in the bulletin, IV push can lead to hypotension and even breath. It was recommended in the bulletin to avoid the routine administration of an intermittent dose of IV phenytoin push. In a second in our lab study, nurses were asked to double the concentration of the IV solution running, but maintain the same dose administered to the patient. When the concentration of an existing bag, it is best to use new tubing IV bag is changed when the infusion pump is immediately programmed to elect this concentration to have a flow rate. The average that will be received by the patient will be half the intended rate, where the shared volume will contain the old concentration until it's cleared and the new concentration reaches the patient. Percent of nurses in our study made this error. This tagged off the ICE Canada Safety Bulletin published in April 2004. The concentration of the norepinephrine continuity infusion used to maintain a patient's blood pressure doubled, and the tubing was left unchanged. The pump adjusted to reflect the new concentration, but old concentration was still in the tubing. The patient to half the dose. Their blood pressure dropped to 40 millimeters of mercury, and a cold blue needed to be called. When we dug deeper to understand the potential contributing factors behind these errors, we identified there was no standardized teaching of shared infusion volume principles in Ontario. This in part because the undergraduate nursing degree programs assumed shared infusion volume was covered in postgraduate specialized training programs. Specialty programs assumed it was taught in undergraduate nursing programs. These education gaps that may not be filled during practice and clinical time for nurses. As part of that study, a very simple prototype e-learning module was developed and tested to help hospitals fill this gap. Fundamental to the module design was to introduce shared volume by making the invisible visible. Application module, shared infusion volume management practices significantly improved in comparison to the baseline condition. Example, as shown here, significantly nurses flushed after administering an IV push dose. In all presented today, y-axis has a percentage of errors, so lower is better, and thus access has the different conditions. However, performance only improved when the module explicitly targeted a specific task and provided users with detailed recommended practices. Participants were to translate the knowledge gained to specific tasks that were not taught. So here, 25% of nurses still used IV tubing when the concentration of infusion had to be doubled, since the model did not explicitly target this task in tubing, although it did provide the underlying principle. Study results underscore the amazing complexity of shared volume infusion. All of our study results in this theme underscore the need for practice and design improvements. The results I have just shared now highlight the need for shared infusion volume education also. There is important to go beyond providing fundamental principles of shared infusion volume. It must help clinicians not only to improve shared infusion volume awareness, but facilitate the development of specific shared infusion volume management skills. Shared infusion volume may be of concern with different medications and with the task infusion setup because it's not visibly obvious. Here are a common shared infusion volume topics that should be included as part of education. It includes the two tasks I have presented thus far: administering an IV intermittent bolus injection or IV push, and changing the concentration of a medication. It also includes additional situations that are based on other research we have done, so we know there are similar knowledge gaps when administering IV infusion via central venous pressure monitoring line or a transducer line. Infusions to minimize shared infusion volume and may change to infusions connected to other infusions, such as initiating, titrating, and discontinuing. completing and administering a secondary IV infusion. And this is issue, the admission of a secondary infusion and setup. And because she highlights that many of these issues I will present in this fourth theme. Members want to have 5 themes. Number 4, do like infusion pumps that independently control the secondary and primary infusions, such as the Hospira Plus. We are focusing specifically on infusion pumps that depend on gravity above the pump to determine whether the primary or secondary IV infusion is running. Literature. And one we had during our observations as nurses, the failure to create sufficient differential between the primary and secondary IV bags. In this wrong set, the primary and secondary IV bags have a visible height, resulting in nearly equivalent hydrostatic pressures. So the resisting setup is both secondary and primary fluids will run together, will be administered to the patient at an indeterminate rate. Another current literature and from our observations is the clamp flow. The IV and so the secondary fluid cannot flow when the secondary infusion is started on the pump. The primary fluid will flow at rate intended for the secondary fluid following the amount of steps. Other issues to secondary infusions were highlighted in the February 2005 ISM Canada Safety Bulletin. Secondary infusions require primary attention. So, evaluated secondary setup errors in 4 different conditions in our simulation study. But today I'll focus on 2 of them. That is, the baseline conditions for nurses set a secondary infusion as is their practice. And nurses, after they were educated on the underlying IV principles associated with setting up a secondary infusion, and then asked to actually set up the secondary IV line. So here are the results. And again, please remember the percentages on my axis, so lower is better. What is shown here is the baseline condition and results were consistent with research in that nurses frequently fail to create sufficient pressure differential between the secondary and infusion. After the education module, error rate in performing this task dropped by half. Also, test scores were statistically improved in comparison to baseline test scores. Now, if we secondary tubing clamp errors in the baseline condition, errors were common, but unlike pressure differential errors, the study results suggest that secondary tubing clamp errors are not a result of gap in nurses' knowledge. In RNAO scores, nurses scored 100% pre and post watching the module, which highlights that all nurses were actually aware of the need to open the secondary clamp, but limited due to a lack of attention and or insufficient feedback from the infusion pump setup. We identified that some errors can be improved with education, but others, like this one, cannot. Overall, we identified practice and design-related recommendations, but the findings presented underscore the need for education. Because of knowledge regarding some of the underlying principles behind setup requirements, such as ensuring adequate pressure differential compromises their ability to complete some or not all setup tasks. Their missions should be indicated, and should include these underlying IV infusion principles, such as the additional we were speaking of, sets and practices, and the shared infusion volume, which actually specifically discuss the secondary IV infusions that are time constraints, but you can watch some of the modules to learn more. Over to Sonia to give you some more information on the modules and how to access them. I'm going to pause here and and pass it to Grace along the moderator in case there are any questions that have been brought up far. Great.
Time, it doesn't seem like we have any questions regarding this particular session. We will move on to the next session, and if you do have questions regarding any of the content, please type it into the Q&A chat box. If you're having audio issues and cannot listen, please, we are recording the webinar, so we will be posting it. If you have any questions about any of the content that you have seen, please feel free to type the questions into the chat box as well.
Grace and Christine. Now I'll give a very quick overview of the e-learning modules that created to fill the identified gaps, some of which were just described by Christine. We did 4 interactive e-learning modules, and the audience of these modules is really all currently practicing frontline nurses, but also they can be used for student nurses. There is one exception, though, that I will discuss a little bit later. And while our initial focus has been nurses, it has also been brought to our attention that the modules may also be applicable to pharmacists and physicians too, given their involvement in the medication administration process. Modules we used in the lab study described by Christine, and then we revised them based on 2 rounds of simulation usability testing with ICU nurses, floor nurses, and nurses doing their post-grad clinical care training. And were also reviewed by 17 nursing and pharmacy experts. To apply best practices based on current research on e-learning, adult education, and modules, I was trying to make them really interactive and engaging. So, for example, in keeping all the questions to the end of the module, as is typically done in learning, we typically start each subsection with an engaging case study and then a very, very challenging question. And with this kind of case study, to make this theory really relevant to and to apply, and so that they can use these case studies to really make it meaningful and practical for. And these case studies, I should highlight, are often based on real incidents that have occurred. Also focus on the underlying principles so that they're applicable to most pumps, infusion pumps on the market. So the intent with these modules really isn't to improve their use of which buttons, for example, to press on a pump, which we sometimes refer to as the knobology, but really they focus on understanding the fundamental principles upon which the infusion pumps work and limitations, so that they really understand the why behind what it is that they have to do with the infusion pumps. And so this, as Christine has mentioned, was really to make the invisible visible. Such a significant contributing factor to many of the current education gaps, because it's just so hard to see what is actually occurring in the IV tubing. To summarize all the best practices in modules with memory aids, and keep the module run times to about 20 minutes, given that clinicians are often trying to squeeze their continuing education into their limited downtime, which is a whole separate issue for discussion some other time. So, 2 modules about secondary IV infusion specifically. They could be viewed independently of each other. A module called Check the Setup really focuses on the physical setup of secondary infusions and the importance of checking your setup primarily above the pump. As Steve mentioned, these modules primarily focus on the issues for gravity-dependent infusion pumps. The focuses on the hazards related to secondary and primary infusion sharing IV tubing below pump, such as administering a pre-infusion at the secondary rate at the start of the secondary infusion, and vice versa, administering some of the secondary infusion at the primary rate. So I'll do a few short clips from the Check the Setup module, so you can get a feel for where these modules have been designed. The first shows an example of the engagement question I showed you, which I discussed at the start of the module. In this case, a nurse hung a 1-liter normal saline bolus as the secondary infusion. At 2 hours, when the secondary infusion is supposed to be complete, The nurse comes back to find significant volume left in the secondary bag, so she reprograms the secondary infusion to measure the residual, which is about 100 milliliters at the secondary rate of 500 milliliters per hour. And the question is then asked to the viewer of, do you hit start? I'll just play the clip now.
Since the volume to be infused 200 milliliters, to match the remaining in the secondary bag. Do you think the start? That is, prior to start, what one change would you make to ensure the remaining secondary fluid is administered at the program's flow rate? The green arrows on the screen to select your response. Is correct. A second hanger and lowering the primary container further in such a patient receives the rest of the fluid in the second container, administering the primary fluid. Let's read lowering the primary IV bag has this effect.
So I see this is a very challenging question, which is really meant to intrigue and engage viewers who may be aware of their knowledge gaps, particularly about secondary infusions, which is something that they often might do many times in one day, but they see gaps about administering non-traditional secondary infusions, such as administering a 1 liter secondary bag or at a fast flow rate of 500 milliliters per hour, which was the case in this video clip. So now a bit through the module, we start to introduce the fundamental physics, kind of really behind why this is the right answer.
Fluid from the tubing is in a downward force due to gravity. This raises pressure in the tubing called hydrostatic pressure. High pressure increases, so you raise the bag relative to the pump. The size of the bag doesn't affect the pressure, only the height. The top of the fluid does.
And if more, we then apply this underlying theory, that is the physics kind of behind everything, to why we have to do some setup tasks when administering a secondary infusion, such as lowering the primary IV bag.
Secondary IV bags with the hanger, the top fluid in both bags is at the same height, or equivalent hydrostatic pressure. In this case, the fluids in both bags will flow concurrently, that is, at the same time. The fluid in the secondary IV bag to infuse first is at a higher hydrostatic pressure than the primary IV bag. This is used a hanger over the primary IV bag, so its pressure is less than secondary infusion.
So we continue to build on these basic concepts and look at some of the more complicated scenarios where additional setup precautions must be taken, such as administering a large secondary IV bag, or the secondary is running at a fast flow rate, which was the case in the question presented at the start of the module. And then after reviewing other fundamental principles of some of the other tasks for secondary infusions, we have this memory aid to really enforce the material covered in the module. And we call this module actually check your setup, partly because we overlay a check mark over the secondary infusion, and this mark calls out the key points to remember so infusions are not set up correctly, but it can also be used to help nurses troubleshoot any setup issues. So the module is called Consider Shared Infusion Volume, and we had time today to review the contents of this module, but actually really walks through the disagreement between what a pump does and what fluid is actually being administered to the patient, because both the primary and secondary infusions share IV tubing. Use this information to reinforce best practices, such as not connecting a secondary infusion to a high alert primary infusion. It also identifies areas where best practices still need to be established, such as what volume should be programmed in the pump given the shared infusion volume and other factors such as secondary bag IV bag overfill. So it will stimulate discussions within the hospital, but also with your professional organizations and vendors, because practices still need to be identified and will depend on the pump that you're using. So here's just showing how we really start to walk through what's actually occurring in the administration of a secondary infusion, again, making the invisible visible.
To help with happening, let's use potassium yellow. We are also placed 2 containers at the tip of the IV tubing, one for saline and one potassium. So we observe how much of each infusion is actually being administered to the patient at each stage of the infusion. Let's see, after the nurse hits start, the pump immediately switches from the primary to secondary flow rate, but the infusing pump does not know what is infusing at the tip of the tubing. The infusion volume contains 40 milliliters of fluid. This is normal saline, not potassium chloride. After the first 20 milliliters of the programmed secondary infusion, the patient is actually receiving normal saline at a secondary flow rate of 50 milliliters per hour instead of 10 milliliters per hour.
So modules we've created are about, again, shared infusion volumes, but other than those relating to secondary infusion. As the secondary infusion modules, these 2 modules should be viewed in sequence and build off each other. So it's a 2-part series. This module is about residual meds that are left in IV lines, and we focus on this on 3 particular situations. The shared infusion volume following an IV push dose, the concentration of an IV bank, and lastly, administering drugs on the CPP line. So focuses on these 3 situations. I should highlight that residual meds can affect other tasks too, such as disconnecting an infusion. And I have a clip from this module because Christina's already kind of touched on some of the content, and we have limited time, because I do want to show a clip from our part 2 of this module. Part 2 in this series really focuses on the much more complex issues of administering multiple continuous IV infusions through one access port. And that this module's primary audience is really geared towards critical care nurses, given that this is where we see most infusions sharing an access port. But some of the principles apply to all units when joining 2 infusions together. But again, the primary audience here is critical care. In this module, we focus on what happens in the shared infusion volume when infusions are connected, and then a change is made to one of the connected infusions. I'll show you a brief clip here.
Let's first look at how administering a single infusion is different from administering multiple infusions connected to the same patient access port. When a single infusion, changes in infusion are instantly reflected at the patient's bloodstream. So, when we increase the flow rate, this results in instant change in the dose received. But, true, when multiple infusions are connected together, the pump functions and changes are immediate within the tubing, but up to the point where the infusions join. Had that infusion creates infusion volume for the tubing now to carry 2 fluids at the same time. And made to one infusion needs to process through this infusion volume before it's received by the patient's bloodstream. So, when multiple infusions are connected and the flow rate of one infusion is changed, there's time delay before the patient receives the intended new dose. Let's make the invisible and take a closer look at the shared infusion volume.
So the complexity of what's actually occurring in that shared infusion volume. Infusion flow rate is increased, and also when it's decreased. Created this kind of deep dive into the therapy and into understanding what's happening in that shared infusion volume. We found our usability testing that it was too much to demand that they apply this theory and think about all these details and they make a change given all their other cognitive demands. Based on the theory, we then kind of bring it back up a level and summarize by creating these 3 rules to really help clinicians develop their kind of conceptual model so they can quickly predict what will happen when they're making a change to a connected infusion and the impact it may have on a critically ill or pediatric patient who may be more sensitive to infusion consistency and accuracy. So what the 3 rules are: when a change is made to a connected infusion, there's a delay before that full change reaches the patient. 2 is on the condition of if you're changing an infusion rate up, the dose of the other connected infusions will temporarily down. The rule is if you're changing the rate of the connected infusion down, the dose of the other connected infusions will temporarily again go down. So, and in this theory and these 3 rules, we then cover some best practices to minimize the shared infusion volume and its clinical impact to patients, such as, for example, using multi-port connectors to connect 3 or more infusions, not overreacting to patient changes while the shared infusion volume is clearing, and important considerations during an IV tubing, a routine IV tubing change. So that's our presentation. But I just want to bring back to how we started this presentation when I was describing how when we first walked around and showed this picture to nurses, the reaction was essentially kind of what's the problem. I'm pleased to say that the tide is really turning, and the status quo does need change and improvement. Here alone, publications promoting the issues with multiple infusions and the need to focus resources on this issue have been identified by organizations such as the Joint Commission of the Association for the Advancement of Medical Instrumentation, who are making this a priority area for the next 2 areas. ERI, who identified that some of the multiple IV infusion-related issues they were included as their top 10 hazards for 2015, and Canada published a bulletin on this issue in December 2014. Today, I do want to stress that while our education modules can help fill some of the gaps that we identified, it's really only part of the solution, as there's still much work to do at all 3 of these levels to improve the safety. Our modules are a good spot to start, and I intrigue you today and you want to see these modules. And so we're going to announce that RNAO has generously agreed to host all 4 of these modules on their website as part of their commitment to patient safety. You need to log in and watch them online, and yes, they are free. We've also heard from many hospitals really a strong desire to download these modules into their own learning management systems so they can assign and track the completion by their frontline staff. So RNAO will have links on their website to Air's website, from which where you can download these files for uploading into your own learning management system. And just a note before I finish today is I do want to remind you that, of course, organizations should only adopt these e-learning modules after careful appraisal of the content to really ensure appropriateness for your local context, for example, your specific infusion pump and your practices. And on that note, I will pass it back to Grace Wong to field questions.
Great. So we already had a few questions answered about where to find the modules and if they are available free of charge. And we just got that. Sonia just explained they are available on elearning.rnao.ca. So we'll go on to the next question. Is there any new information on TKO rates, particularly with multiple infusions?
That's a great question. It's something that the modules really didn't get into, and rates can vary depending on what kind of access line you have in order to keep that vein open. So peripheral IVs may with a lower rate, whereas some of the central lines, and I'm thinking specifically of venous hemodialysis catheters, may need a greater flow to keep open. And it all depends on the pressures that are the biomed set your pumps to.
Okay, so is the need to run a secondary infusion below a maximum flow rate to prevent unintended concurrent flow from the primary line wasn't something I was previously aware of. Is the same for all infusion pumps?
answer is no, but I'll set up by saying I would encourage you to check with your vendor or check with in your manual on what flow rate that is. There's multiple factors that affect when concurrent flow can occur, not only the head height differential between your primary and tray bag, but also the characteristic of the back valve in the primary IV tubing, the viscosity of the fluid, and many other considerations. Just have come up with guidance on what to do that's most appropriate for their infusion pumps, and some pumps even won't allow you to program a flow rate of a secondary infusion pump above that value. So it's important that you go back and look at what's required for your specific infusion pump.
Thank you. The next question is, I have a clamp on my primary IV tubing to prevent concurrent flow when administering a secondary infusion, instead of lowering the primary IV bag. Is this an acceptable practice?
Excellent. I'll try and answer this one. Some primary IV tubings do come with clamps on them, but interestingly enough, it's not the best is to use those clamps, and really have to check with the vendor if that's what they intend. Now, I know that probably shouldn't be a clamp if you're not supposed to clamp it, but again, you have to check with your vendor if it's okay to clamp that primary tubing. And certainly if there's no clamp there, please check with your vendor. Don't use hemostatic clamps and things like that, because it can affect tubing.
I'll add on to that we've seen an issue where some nurses develop their practice of instead of dropping the bag, of clamping the primary IV tubing as a fail-safe way of preventing concurrent flow. But seeing them become an issue if their hospital migrates to a new infusion pump, or they change hospitals themselves now have IV tubing, primary IV tubing, which does have this clamp. So I wanted to reiterate that even if it is your practice to clamp the line, these modules, in terms of understanding the fundamental principles, would still be applicable, because it's important that you have that understanding knowledge.
Great point. Thank you.
Question is, do you use these modules to meet Accreditation Canada's infusion pump training requirements?
Okay, the answer there is that you really need to confirm with Accreditation Canada to clarify. But it's my understanding that they do kind of comply with the intent, or can supplement your requirement to meeting that Accreditation Canada requirement. I think they're, if I remember correctly, the SOP for relating to infusion pump is that there's evidence that you show evidence of ongoing training about infusion pumps. I think a lot of it was just to make sure that people know the focus on the biology, but I think it would be an excellent example of showing leadership on that, by showing that you're also looking at applying and complementing it with education modules. And if you include learning management system, it's an easy way to show evidence of the compliance with that requirement as well.
Questions? We just got one more. Going to the shared infusion volume, when secondary infusion added, what is a practical solution to correcting the error of administering the solution that remains in the shared tubing at the rate of the secondary infusion?
The simplest ways to prevent or to minimize the impact from that is to make sure you're not connecting your secondary infusion to a high alert primary infusion, because then you are minimizing the impact. If you're just connecting it to a normal saline line, then administering that at a slightly faster rate realizes the impact of this issue. This idea of this time delay in the tubing is something that is kind of hardwired into the design of the pump, and so it is something that we have to kind of look at minimizing the impact, as opposed to in the current design, there's no way of completely eliminating the issue.
I think those things that people have to have a conversation about and to try and determine what practices are within their local areas. When you're using the secondary infusion, that may not be an issue if you're hanging another medication right after it, because the volume will go through. But it's important to be aware if there's really huge differences in rate between medications, one after the other, to really to start increasing that awareness and making that visible.
Okay, one last question, and then we'll move on to the closing. So thank you for bringing the issue of shared IV volume to the forefront. I believe you mentioned it could be an issue when discontinuing an IV infusion. Could you give an example of this?
Yeah, this question, because it's those things that I think can be very important and critical to know, whether you work in a general medicine unit or in surgery. If you can picture, I'm going to give you an example. Let's say a patient is on an on-drip of a continuous pain medication, and you have, and you're finding that there's some adverse effects from that drip. When you discontinue that line, let's say it's morphine or some other medication, you have to appreciate that there is still medication in a shared volume of that tubing. So if you remove that medication, the plain line that is now running will still have that medication in the line. So it can become very critical when discontinuing something for a reason. And what we want and hope this does is really create awareness and have people review e-learning modules and looking at what is the best practice here, so that we make the right decisions given what is going on.
Thank you very much, Sonia and Christine, for sharing your expertise, and there are some questions that were asked today. Just in terms of a quick wrap-up, just want to let you know again, in terms of complementary guidelines, the Bachelor Access Assessment and Device section, as well as care and maintenance, are available for free download on the website. And in the near future, this is where the archived webinar of today's presentation is also going to be posted, in addition to, if you look on the next page, also the access to the e-learning module, the Multiple IV Infusion Safe to eLearn. And it was, as I said, developed by Human Era, funded by Health Quality Ontario, and hosted by Registered Nurses Association Ontario. So on the website, if you go to online courses and then go IV Infusion, you should be able to find it. Then, the webinar evaluation. If after the webinar is ended, if you can please fill out the webinar, you'll be redirected to the survey. And if you take 2-3 minutes to complete it, that would greatly assist us in evaluating the webinar and allow us to plan for future webinars. And additional questions, please contact Grace Wong at rnao.ca. She'll be able to answer questions with regard to this presentation or any access to the materials that we talked about today. And if you're willing to enjoy this presentation and would like to access a webinar future, please visit our website at the events page at www.rnao.ca. This ends our presentation on multiple IV infusion safety and education implications today, and thank you very much.
Thank you.